Really appreciate everything that's been said so far. I'm actually not going to be speaking about somatostatin analogs right at the moment, since we have a talk that will be on that subject tomorrow morning. I'll be speaking about it then. And I'm not going to be talking at the moment about multidisciplinary approaches and combining chemotherapy and biologic therapy with other treatments, because that's going to come in a few minutes when we have a multidisciplinary panel discussion. Instead, what I'm going to do right now is to talk about chemotherapy and biologic therapy, what's new in 2010, so we have some idea about the kinds of treatments that are out there, what's on the cutting edge, and what's really new in this regard. There's a drug called Temozolamide, which has gotten a big press in recent years and a big use in neuroendocrine tumors, and I wanted to be sure that we're all up to speed on this drug. An older regimen, which is some people still think of as the standard treatment, involves a drug called streptozotocin, and in combination with doxorubicin and 5-FU has an objective response rate of probably 39%, which is pretty significant. The partial response rate means that about half of the volume of cancer is reduced by the treatment. It's a major shrinkage of cancer in about 39% of patients in the best analysis that Dr. Yao has reported. When you use temozolomide as a single drug, the response rate is about 14% measured by the same criteria. However, another 53% of patients have stability of their disease where it doesn't progress, so that most people end up with a major clinical benefit. And rather than being a toxic intravenous program like the streptozotocin doxorubicin 5-FU program, this involves a very low toxicity oral pill. People have tried combining temozolomide with bevacizumab, also known by the brand Avastin, which has maybe a little extra benefit, but not a whole lot. But what has made a huge difference is the combination with another well-tolerated little pill, which is an oral form of 5-FU known as Capecitabine or Xeloda. So this combination of Xeloda with temozolomide, also known as Temodor, two kinds of pill chemotherapy, very well tolerated. 17 patients with pancreatic neuroendocrine tumors were treated in one study with this particular combination. 71% of people had a major objective response, and another 29% had stable disease for a year, which meant that almost everybody had a really major benefit, and again, with very low toxicity. So this is quite different than the past experiences with much more toxic types of intravenous chemotherapy. There was another study that was done using temozolomide prediction with an enzyme which is called MGMT, methylguanine methyltransferase. It's too big a mouthful to say, so we call it MGMT. It's a cellular enzyme that repairs damaged DNA. And it turns out that temozolomide kills neuroendocrine cancer cells by damaging their DNA and leading to cancer cell death because of that. When MGMT is high in a cancer cell, the DNA damage is repaired and the cell survives the effects of chemotherapy. And when the MGMT is low, temozolomide is able to kill the neuroendocrine cells quite effectively. And fortunately for people with neuroendocrine tumors, most patients actually do have low MGMT and do have a good result with temozolomide, as I've shown you. In people that have high MGMT, in a study that was done by Matt Kulke in Boston, none of the patients seemed to respond to temozolomide. And when the MGMT was low, most of the patients responded in the small numbers in the preliminary trial that was done. So this is something that we have to watch out for. We may be able to have a good predictor of who temozolomide will work in. I also wanted to give you a little overview of some of the targeted types of therapy that work on molecular pathways, some of which you have already been hearing about, that are in cancer cells and particularly in neuroendocrine tumors. The unique chemical makeup of neuroendocrine cells make them ideal targets for the use of targeted therapies. The neuroendocrine cells have an increased density of blood vessels and substances that stimulate blood vessel growth, like vascular endothelial growth factor, known as VEGF. When tumors have this kind of situation, they're able to be treated with anti-angiogenic drugs that can be quite effective. The neuroendocrine tumor cells have increased tyrosine kinase growth factor receptors like EGFR, epidermal growth factor receptor. And when patients have this type of situation, there are drugs that can target these particular receptors. These are often pills, often well tolerated, and can be quite effective. And you'll be hearing about drugs from all of these categories over the course of the next 2.5 days of meetings. Genes involved in maintaining the malignant state are overactive in neuroendocrine tumors and are being identified and are being targeted with specific therapies. So there's really a lot of hope that in addition to traditional types of chemotherapy, a lot of special targeted non-traditional types of chemotherapy, if you like, if you want to just use the word chemotherapy to mean any systemic cancer treatment, if you want to use it that way, you can say that there is a new type of chemotherapy which is going to hopefully revolutionize the whole field. I'm going to give you a few examples of some of the types of targeted drugs that I've been particularly excited about and share this with you. One is a drug called atipramod, which encourages tumor cells to drop dead. There's a process called apoptosis, where cancer cells will preferentially die, and this drug stimulates that sort of pathway. And patients treated with this well-tolerated oral drug had a 92% chance of being stable for a prolonged period of time, and 50% had no growth of tumor over a period of a year, potentially a drug that can be combined with other types of chemotherapy and be important. There are a few patients that have severe liver toxicity, although it's very, very rare with that drug, but for most people it's very well tolerated. Another exciting pathway is the so-called mTOR pathway. mTOR is a central regulatory enzyme found in neuroendocrine cells. It's actually found in every cell in the world, but it's found in excess amounts because of certain mutations that happen in neuroendocrine tumors. And we can target mTOR, which results in increased neuroendocrine tumor cell death, decreased rate of growth, decreased rate of metabolism, and has beneficial effects. The efficacy of one of the nice mTOR inhibitors called RAD-001 or everolimus is an oral, well-tolerated in general mTOR inhibitor. In the use of this drug in treating low to intermediate grade neuroendocrine tumors, the first major study was published recently with Dr. James Yeo as the first author. And 22% of patients had a partial response to this type of pill, with another 70% having stable disease for a prolonged period, and only 8% of people had disease progression when they were taking this. Progression-free survival, which means how long you can just remain comfortable without any growth of cancer, was 60 weeks. And some people I have had on this drug literally for years without cancer growing, but the average is 60 weeks. Median progression-free survival with patients who have stable disease when they first started was even longer. The average progression-free survival, 74 weeks, which is a very, very long period of time, and one of the best progression-free survival intervals you'll see in the literature with almost any type of treatment. Median survival has not yet been reached at the time of analysis because so many people are alive and well. And at the end of 3 years, 78% of people were living and doing okay. You can see. Most common toxicity was mild soreness in the mouth. Serious toxicities were uncommon, but some people had problems with fatigue or diarrhea or low blood phosphate, and those kinds of toxicities could respond to reduction in dose in most cases. Interestingly, the Ki-67 that you've been hearing about as a biologic property of cancer cells is not a static number. It not only is variable between one part of a cancer and another in many cases, but actually is changed by therapy. And if you look at what happens to the proliferation of cancer cells when they're treated with a drug that slows down proliferation, the Ki-67 goes down. And when you look at the results with the mTOR inhibitor, RAD-001, the Ki-67 in patients who were responding to treatment became much lower than it was when they started out. So just remember that this is something that depends not only on where the biopsy is taken, but at what time the biopsy is taken. If it's taken at the time when people are on treatments that might be lowering proliferation, you'll have a lower proliferative index. mTOR inhibitors are also potentially extremely active when combined with a variety of kinds of chemotherapy, biologic therapy, and growth factors, and I think we're going to be seeing new generations of studies using those medications in the years ahead, so you want to be aware of that. I'm going to talk for a moment about anti-angiogenic drugs, the drugs that stop the cancers from growing by starving them out, by hurting the blood vessels. Remember I told you about the VEGF. Bevacizumab is the one which has been studied the most. It goes by the brand name of Avastin. This is a monoclonal antibody to VEGF, which blocks the ability of that drug to work. It's usually well tolerated, but in some people can cause an elevation of blood pressure, can cause blood clots or bleeding or problems with wound healing, so it should be used by people experienced in its use. It has a 24% response rate when used by itself. However, when you use it with other types of chemotherapy and biologic therapies, the response rate may be significantly higher than that. It's also being used in carcinoid tumors. There's a large multi-center study that's being done right now, which is a phase 3 comparison of octreotide in combination with Avastin, with bevacizumab, and other types of systemic therapies as we go, but I wanted to focus this discussion on these issues. So I want to thank you very much, and we'll be talking about it.